Hello, my name is Atif Darwish, Professor of OPGO in Asset University, Egypt. I'd like to discuss with you an important and very controversial topic of poor ovarian response. It is enigmatic and ambiguous topic because there is an overlap between a poor ovarian response and poor ovarian reserve despite not being synonymous. Now, the definition of poor response is again controversial because some mentioned that it means failure to produce an adequate number of oocytes of good quality suitable for IVF ESHRE, and that's why many cases will have a cancelled cycle after the starting stimulation and downregulation. But this definition is not sufficient to define poor ovarian response because it focuses on the quality and the quantity of oocytes, but other factors for poor response are ignored in this definition, like poor induction protocol, poor selection of drugs, and poor triggering, and so on. So the definition should be broader than focusing on the oocyte quality and quantity, because if we concentrate on the oocyte quality and quantity, this is a poor ovarian reserve rather than being poor response. The ovarian response is good oocytes suitable for fertilization, and as a single or multiple haploid blastocyst is formed. The basic description of poor ovarian response relies on the ESHRE consensus, which is Bologna criteria, including at least two of the following three, including number one, increased maternal age more than 40 years, or any other risk factor for poor ovarian reserve. A previous poor ovarian reserve, which means or poor ovarian response, which means less than 3 oocytes with a conventional stimulation protocol, or an abnormal ovarian reserve test like intrafollicle count less than 5 follicles per ovary, or anti-mullerian hormone less than 0.7 to 1.3 nanogram per milli. So this definition is used for the ESHRE groups of research, and actually if you look to this definition in details, you will find some heterogeneity in description of this poor ovarian reserve. Lines of treatment based on the Bologna criteria include pre-treatment therapy, controlled ovarian stimulation, LH suppression regimen, triggering protocol, triggering approach, natural or minimal stimulation protocol, or adjuvant intervention. If we go to every point in short, they mention that pre-treatment therapies, including estrogen therapy, progesterone, GnRH antagonist, pre-treatment before controlled ovarian stimulation, use of COCs, pre-treatment, all these are not recommended in the GnRH antagonist protocol because of reduced efficacy. All these are not recommended. Estrogen, progesterone, GnRH antagonist, or COCs are not recommended according to the ESHRE guidelines, and the use of COCs is not recommended in the GnRH antagonist protocol with a strong evidence. What about controlled ovarian stimulation, which is gonadotrophins? The dose of gonadotrophins actually rely on the type of poor ovarian reserve. If it is poor, you can start by 3 ampoules of 75 international unit up to 5 ampoules. If the patient is high responder, you can start by just 2 ampoules. If she has an average ovarian reserve, you can use 3 ampoules, 225 international units. The Increased dose more than 4 ampoules, which is more than 300 international units, is not recommended according to the ESHRE guidelines. The controlled ovarian stimulation protocols for predicted low response, you can see from the ESHRE guidelines that use of clomiphene citrate plus gonadotropins versus gonadotropins alone is equally effective. The use of letrozole plus gonadotropins is not recommended. The gonadotropins more than 300 international units versus 2 ampoules, which is 150 international units, is probably not recommended. And importantly, to know the type of gonadotropins, they mention that recombinant FSH versus HMG, or recombinant FSH versus purified FSH, recombinant FSH versus highly purified FSH, highly purified FSH versus human menopausal gonadotropins, recombinant LH plus recombinant FSH versus HMG. All these modifications, they found that there was no difference regarding the response or the improvement of cases of poor ovarian reserve, and this is a strong evidence that there is no difference between different protocols of using different types of gonadotropins. The use of long-acting and daily recombinant FSH is equally recommended in GnRH antagonist cycles for normal responders, which is a strong evidence. Lastly, letrozole as a substitute to gonadotropins in low responders is not recommended. The adjustment, which means increased or decreased dose of gonadotropins beyond stimulation day 6, is probably not recommended and is not effective. What about the LH suppression regimens? LH suppression regimen can be GnRH agonist. Using long GnRH agonist protocol is probably recommended over the short or ultra-short protocol. What about the GnRH antagonist? It is recommended over GnRH agonist protocol given the comparable efficacy and high safety in the general IVF-XC population with a strong evidence. Progestins for LH peak suppression is not recommended. So the options for poor responders is to decrease the length of suppression by decreasing the duration of GnRH agonist use, which is short and ultra-short mini or microdose flare-up regimens, to lower or stop the dose of GnRH agonist initiated during the luteal phase, to use the GnRH antagonist and gonadotropins to prevent premature LH rise during the mid-late follicular phase. It is recommended to use GnRH antagonists and GnRH to prevent premature LH This is not an ESHRE recommendation. It's a recommendation by some other authors that the protocol for low responders is to use antagonists, is to use microdose flare-up, agonist stop, growth hormone, natural modified, natural proteins. Now, what about triggering for the cases of poor response? We have HCG triggering, which is used 36 hours before oocyte pickup, and this may lead to increased incidence of ovarian hyperstimulation syndrome. Another type of triggering is to use GnRH agonist 36 hours pregnancy ovum pickup, and this protocol leads to less incidence of ovarian hyperstimulation, but decreases pregnancy rate and increases pregnancy loss rate and miscarriage rates. So combination of both, which is HCG plus GnRH agonist, is called dual or double protocol induction triggering protocol. We give GnRH agonist 40 hours and followed by HCG 4 hours later, which means 6 hours later, which is 34 hours prior to ovum pickup, to have double triggering to improve pregnancy rate and increase number of mature oocytes retrieved. So it makes advantage of the HCG and GnRH agonist protocols. Double triggering offers an additional benefit to poor ovarian response. What about natural or minimal stimulation protocol? The ESHRE mentions that modified natural cycle is probably not recommended over conventional stimulation protocol, including mild ovarian stimulation for IVF, which is monotherapy or combination therapy of clomiphene aromatase inhibitors, gonadotrophin, GnRH antagonist, late follicular phase, HCG or LH, or low dose mild IVF protocol, GnRH antagonist involving delayed low dose gonadotropin stimulation until mid-follicular phase, anywhere between day 3 and day 7, to achieve development of fewer oocytes than traditional IVF with reduced gonadotropin dose and low cost, or modified natural cycle IVF. These protocols are not in favor of using in cases of poor ovarian reserve, and another study published in the fertility sterility found that natural cycle versus conventional IVF study comparison found that there is fair to good evidence that clinical pregnancy rates are not substantially different using mild stimulation protocols compared to the conventional IVF protocols in poor responder populations. And last recommendation by the ESHRE guidelines is the adjuvant injection. They mention that the use of adjuvant, growth hormone, aspirin, sildenafil, all these adjuvants are probably not recommended for poor responders. The routine use of adjuvant metformin before or during controlled ovarian stimulation for women with polycystic ovarian morphology is probably not recommended with strong evidence. These were the ESHRE recommendations, and lastly, GnRH agonist bolus or LH, in addition to progesterone for luteal phase support in HCG triggered cycles, can only be used in the context of a clinical trial, and repeated GnRH agonist injections alone or in addition to progesterone for luteal phase support in HCG trigger cycles can only be used in the context of a clinical trial. So what about the role of dihydroepiandrosterone? And you know that this hormone is formed from 17-hydroxypregnanolone, which leads to formation of androstenedione as an end product in the theca cell of the androgens, which enters to the granulosa cell and under the effect of aromatase enzyme leads to formation, ultimately into formation of estradiol. So dihydroepiandrosterone is an important hormone to form estradiol. So if we give dihydroepiandrosterone sulfate, it has a critical role in adequate follicular steroidogenesis and early follicular and granulosa cell development. It increases FSH receptor expression in the granulosa cells and potentially enhances the responsiveness of the ovaries to the FSH. So it is an important hormone and may be effective in improving the quality of the folliculogenesis and steroidogenesis in the ovaries, particularly in women with poor ovarian reserve. The use of dihydroepiandrosterone before or during controlled ovarian stimulation is probably not recommended for low responders as recommended by the ESHRE guidelines, and the use of testosterone is probably not recommended as well. So these were the ESHRE guidelines based on Bologna criteria. And lastly, they mentioned the PRP, which is plasma-rich platelet-rich plasma injection into the ovary is not recommended so far because we are waiting for large randomized controlled studies to confirm the efficacy and safety in various gynecological disorders. On the other hand, we have another classification of poor responders according to POSEIDON criteria, which classified patients into 4 groups, and this POSEIDON is an acronym of patient-oriented strategies encompassing individualized oocyte number. They classified the patients into group 1 and 2 and group 3 and 4. 1 and 2 are groups of patients with good ovarian reserve test as detected by biophysical testing of antral follicle count more than 5 and biochemically by antimolar hormone more than 1.2 nanogram per milli. And those cases are subjected to the optimal and ideal ovarian stimulation protocol, conventional protocol, but unexpectedly they produced poor response. So they are poor responders unexpectedly, and they are group 1 and 2. One is group younger than 35 and group 2 is more than 35, but both have the same scenario, which is good simulation, good selection of cases, but the response is poor. And the group 3 and 4, from the beginning, you know that they are poor responders as evidenced by biophysical and biochemical testing. Again, group 3 is younger than 35 and group 4 is older than 35. They classified these 2 groups of unexpected poor ovarian response or expected poor ovarian response into a group with less than 35 or more than 35 because young patients have lower embryo aneuploidy risk while the older patients have higher embryonic aneuploidy risk. So they classified the unexpected or expected ovarian response into subgroups, which is group 1 and 2 and group 3 and 4 according to the future or expected aneuploidy risk for the embryo. The first talk will be on the group 1 and 2, which is unexpected poor ovarian response despite good ovarian reserve testing. So these patients will have low follicle oocyte index, which means the number of starting follicles is good, but the oocytes retrieved are less than expected. They are called hyporesponders to the conventional stimulation protocols. And actually, hyporesponse may be due to decreased sensitivity of the follicles to the exogenous FSH, may be due to environmental contaminations, oxidative stress, and this may highlight the effect or the role of antioxidants. And so group 1 and 2 should be treated in a personalized manner and with tailored stimulation protocols. What about pre-treatment? They mentioned that we have to consider ART calculator, consider FOI, consider genotype screening. Some specific genetic FSH receptor polymorphism has been detected in some patients. And you have to consider androgens in group 2 with ovarian reserve markers in the lowest limit. The androgen induces FSH receptors on the granulosa cells. This is FOI, which is follicle oocyte index, which means that the oocyte number retrieved versus the antral follicle versus the starting follicle at the start of stimulation number. If the number of retrieved oocytes is less than 50%, this is called low FOI. If it is more than 50, it is normal FOI. And this can be attributed to genetic or environmental factors, asynchronization of follicular development, but some technical problems like triggering problems or low dose of GnRH of gonadotropin starting dose. In cases with low FOI, clinicians should consider pre-treatment, including short-term of estrogen, progestin, COCs, to achieve synchronization of the follicles prior to stimulation. we can consider adjuvant LH activity during stimulation, changing the trigger strategy to either dual or double trigger. So this is another difference between the POSEIDON criteria and Bologna criteria. The ART calculator is a computer program which includes, you have to enter data pre-treatment like age, like semen quality, and to estimate the number of mature oocytes, and post-treatment is the actual number of collected mature oocytes, and you have to correlate between both, and you can calculate the predicted probability of achieving at least one haploid blastocyst with the number of mature oocytes available. In cases of insufficient number of oocytes retrieved as determined by ART calculators, the probability of transferring an haploid embryo, normal embryo, should be discussed with the patient to counsel them whether to have immediate transfer or a new stimulation protocol, because the risk is high in such a case. What about controlled ovarian stimulation protocol? They mention that for group 1 and 2, it's recommended to use recombinant FSH rather than HMG or other types of stimulation because of high biopotency of the recombinant formulations. You can increase the dose of FSH by 50 international units of the initial recombinant FSH dose to increase the number of retrieved oocytes, and you can use recombinant LH. These are completely different recommendations if compared to Bologna criteria, and this is the differentiation between group 1 less than 35, group 2 which is more than 35 of using of recombinant FSH and adding LH to the group 2. Use of recombinant LH of 75 to 150 international units either on day 7 to 10 of the stimulation in an attempt to rescue an ongoing hypo response, or from day 1 of stimulation in a subsequent cycle to increase the number of growing follicles and subsequently the number of oocytes. So it is beneficial for two groups of patients: POSEIDON group 1 and 2, older patients 37 to 39 years old. The rationale is increased androgen production, and androgen are then aromatized to estrogens and help restore follicular milieu, and actually the action of LH at the granulosa cell level enhances response to FSH, and LH has also a direct positive effect on the final oocyte stimulation. Importantly, they recommended double stimulation protocol, which is DUSTIM, which means you make follicular phase stimulation as well as luteal phase stimulation during the same cycle to achieve better results and increase or maximize the number of oocytes obtained per cycle. What about the triggering? They considered antagonist regimen and general H agonist triggering and elective embryo frozen in cases of intrafollicle more than 16 and MH more than 3.3 nanogram per milli. Consider pre-implantation genetic testing for aneuploidy in POSEIDON group 2 older than 35, particularly patients more than 38, and consider single blastocyst embryo transfer. What about adjuvant? You can give dehydroepiandrosterone supplementation before ovarian stimulation to counterbalance the impaired theca function and androgen production observed in women with advanced age. You can prescribe 75 milligram daily for at least 12 weeks prior to ovulation, ovarian stimulation, and significantly you can achieve higher life birth rate. Pre-treatment therapies, you can consider, in particularly in cases with low FOI, you should consider short-term estrogen therapy, synthetic progesterone or COCs for synchronization with follicles prior to stimulation, adjuvant LH activity during stimulation, or changing the trigger strategy to either dual or double triggering. So this can be you can prescribe high dose of recombinant FSH, which is 4 ampoules of 75 international units in group 3 and group 4. Add to it 2 ampoules of recombinant LH, which is 150 international unit, and this is the induction protocol for those cases. What about triggering? You can use double triggering or dual triggering for such a case, which is based on the FOI index, which as I told you, if it is low, less than 50%, it is low. If it is more than 50%, it is normal. Regarding adjuvant intervention, they recommended growth hormone or coenzyme Q10 for the groups 3 and 4. Growth hormone itself and through insulin growth factor 1 has a synergetic effect with FSH on the follicular development. Coenzyme Q10 decreases mitochondrial oxidative stress and improving oocyte competence. In conclusion of the POSEIDON criteria, they mentioned that randomized controlled trials for all these recommendations are needed to settle the rule in each group A, 1, 2, 3, and 4. And we have to search for in vitro follicle activation, autologous mitochondrial transfer to improve the implantation rates and quality of embryos. And lastly, we have to search for development of oocytes from stem cells for such cases, which is a new era of ovarian rejuvenation. If you like this lecture, please press on the like icon. If you need more publications, more lectures, you can press on the subscribe and notification icons as well. And you can keep in contact with me by email atif_darwish@yahoo.com. And thank you very much and see you again. Bye bye.